The main thing that we're doing in the UK is moving towards our next trial, and we're in the process of publishing our results from UKALL14. We're still, the COVID pandemic has made that slower, but we're about to publish some data showing that the ICROS gene in our patients, with the largest trial in the world occurring over the last few years, does not appear to affect outcome. So that's very different to the French data. And then we are going to publish a paper about giving 4 doses of rituximab to all people with B-cell ALL, and we found that although the outcome was slightly better, it wasn't statistically significantly better. So 4 doses did not improve the outcome as much as was seen in the GRAAL study, which they published in the New England Journal a bit back. So hopefully, however, people will give rituximab to patients with CD20 positive ALL, but they probably need to replicate what the French did and give 16 doses. We're also going to quite soon publish our results of reduced intensity transplant. That's work I'm doing. We've got data on about 270 patients, and we just need to update their survival. But when we last looked, this group of patients treated uniformly with fludarabine, melphalan, and ChemPath, they had 60% 3-year overall survival. And that's really very encouraging. If we look back to the last trial, that same group of patients had about 20% survival. So we really do believe we've improved things. One of the things, we're very pleased with those data, but one of the things we've done in the UK is we've about a year and a half ago launched a randomised trial of 2 conditioning regimens for reduced intensity transplant, and that's a trial called ALL-RIC, and it's run by the organisation Impact. Until recently, I was the medical director of that. That's our version of the Clinical Trials Network, the BMT Clinical Trials Network. It's our national transplant trials forum, and what we're doing is we're comparing fludarabine, melphalan, and ChemPath, which is what we used in UKALL14, with a low-dose TBI regimen, 8 gray with cyclophosphamide, and the goal is to reduce relapse and further improve survival. The other thing we're going to do, which we just don't, the data are not quite mature enough. Within UKALL14, we did a randomisation of nalarabine consolidation, and those data just need a little more maturity. There really are some suggestions that nalarabine used up front may be efficacious. The trouble is that T-cell ALL is quite a rare disease, and it's very hard to get large enough numbers of patients to do randomised trials. In the pediatric and young adult group, this is some data from the Children's Oncology group from COG, which they presented at ASCO in 2018. They showed that the people who got 5 courses of nalarabine, that those children and young adults did better. And it's very suggestive that this is an important advance in T-cell ALL, but as I said, hard to do a big randomised trial. I think our trial was the biggest one in the world, over that period of time, and it's still hard to accrue enough patients. But those are, I think, the sort of main develops. There'll certainly be lots of data about CAR T cells. We've got the extremely impressive data in children and young adults up to the age of 25, but people above the age of 25 are they don't have access to CAR C cells, ALL patients. And so this is a major gap. But there are some data from Kite and from Celgene that are going to be presented.